there. Hello again. Today, we've got our final show, and I'm interviewing Dr. Abdul Kadir Slocum of Chemothermia in Istanbul. So first of all, I'd like to say welcome. I'm honored to be talking to you.
Thank you very much, Chris. I'm honored also to be on your show. Very nice to talk to you.
Well, we like it to be a chat and we like it to be fun, but the principle is always the same. We're trying to get tips and information out to people who have cancer so they can improve their personal odds of survival. That's what we've always said, and that's what we do. But just tell me now, I mean, you were born in America, and then you got your degree in Istanbul, and then you met two other guys who are oncologists. How did you all come together, and what was the aim of Chemothermia?
Like our story goes back to 2010 or so. We're a conventional medical oncology clinic, and me, Dr. Berkarda, and Dr. İkesici are working together, the three of us, together with our staff. And our story mainly goes back to us asking the question, can treatment outcomes in oncology be better? Yep. How can they be better? What can be done? And coming to this point, you first have to realize the shortcomings of the standard therapies. And then after accepting, which is not always easy for a practicing physician, we started to ask what can be done. And we started reading, researching, looking for evidence-based therapies that can be incorporated together with conventional therapies, and asking, can we practice our conventional medicine differently, in a better way? And that's how we came to our current point. Team-wise, like Dr. Berkarda is currently 90 years old. He was born in 1932. He's the first medical oncologist of the Turkish nation. He was educated in the United States at University of Rochester, and following completing his medical oncology in the States, he came back to Turkey and founded the Department of Oncology in Turkey. So he's the first oncologist of the Turkish nation. Dr. İkesici likewise is one of the best in Turkey also. So three of us are practicing together, and we came to the point, like Dr. Berkarda, following practicing standard of care oncology for around 40 years or so. Mainly him, and when we all came together, started working on developing complementary approaches with the aim to improve outcomes in the field of oncology.
I think that's interesting, because actually I was talking to Patricia Peat in Monday's show, and we were both talking about the fact that quite a lot of oncologists give patients a drug and they scan them after 3 months and then say, oh, it's not working, and chuck it away and go on to another one. They never try and make the chemo drug work better, or find ways.
Exactly.
And so
like
that's what
our difference. Our difference is mainly, that's one of our important differences. Like we aimed to improve efficacy of our conventional therapies. So not rejecting our conventional background, but trying to potentiate the effectiveness of conventional therapeutics, while also incorporating complementary therapies that will work synergistically with each other and also with our conventional therapies. And also, like while going into this, we came across with much more evidence than we ever expected, like because normally when you have a conventional background, complementary or so-called alternative therapies are said to have no evidence behind them, so you don't expect much to see. But as you, if you have an open mind and as you read, you actually see there's much more than you ever expect. And it was a journey, reading, going through all the literature and adding on therapies to our protocols that later we saw translated into very serious clinical efficacy, both quality of life wise, but much more mainly survival wise.
Right, I agree with you. I am, I should tell everybody that I've had a patient for about 5 or 6 years who's actually become my friend, and you treated him about 4 months ago, and he came back. We had a lunch together when I was over in England about 6 weeks ago, and he was talking all about you and praising you. So, and I know his scans. He just had some scans, and they were still excellent. So he was
very good.
He was very happy. So he came over to you. He's got colorectal cancer. He came over to you, and you did your standard protocol on it.
Yes.
Him, I understand.
Yes,
so
correct.
Let's just sort of. I want people to understand what you do in simple terms. So talk me through his standard protocol, because you use a number of things, didn't you? Fasting, hyperbaric oxygen, hypothermia. And
yes.
So talk me through how you do it. We'll look at each little bit in turn, if we may.
Yeah, of course. Like, firstly, if we count our proponents of our therapy, the first main one is metabolically supported chemotherapy treatment, which is the way we have named it. Besides metabolically supported chemotherapy treatment, we use hyperthermia, whole body and local hyperthermia, hyperbaric oxygen therapy, supportive infusional therapies of high-dose vitamin C, DMSO, B vitamins, specific metabolic inhibitors, immune-supporting infusions. Also, the diet of the patient is very important for us. Based upon their diagnosis, personal well-being, stage of disease, we decide on their diet. Ketogenic diet is something we recommend to some of our patients. To others, we recommend a more refined, personalized diet, let's say. But diet is definitely an important part of our treatment protocols. And besides these, we use some repurposed drugs and also supplements in our treatments. In metabolically supported chemotherapy treatment is a chemotherapy application method which we have named and which we think will possibly become one of a standard practice in the future of oncology. Why? Because our in this approach of chemotherapy application, what we're doing is actually we're using the same conventional guideline-based drugs. So we follow the guideline-based algorithms and drug choices. Meanwhile, what we say differently is we say, okay, let's apply these drugs, but let's apply them while the tumor is under metabolic stress.
Yes.
Because we believe that cancer has a metabolic basis to it. And because of this, we believe that metabolic stress conditions make tumors much more vulnerable to any treatment that you will be applying. So the most important treatment, which in our conventional approach is chemotherapeutic agents, and these drugs must be applied in a metabolically vulnerable condition, under metabolic stress conditions. And because of this, what we do is we initially recommend our patients to fast prior to chemotherapy application. The minimum time of fasting is 14 hours. So they'll start, as an example, from 6 p.m. The night before their chemotherapy, and then they'll come in around 8 a.m. the next morning for their chemotherapy treatment.
That would reduce sugar and their insulin, yes?
Exactly. That will lower the blood sugar levels. It will sensitize them. So in a basic layman's approach, it will get the tumor hungry. because its main source of energy is glucose. After doing, besides the stress on the tumors, fasting also increases what we call the resilience of our normal cells, of our healthy cells, to toxic chemicals also. There is several research coming out recently regarding fasting, minimizing the side effects of chemotherapy. When we started applying chemotherapy like this, there wasn't so much evidence of fasting reducing side effects, but in the last 5 years, very sound research started to come out. We started doing this back in 2010 or so. And after the patient comes in a fasting state, we also apply minimal doses of insulin to reduce glucose levels even further to a mild hypoglycemic state. The reason of this is to cause an acute metabolic shock.
Yes.
Because that shock and that acute stress on the tumor is crucial as it translates what we see. It translates into important clinical efficacy. Together with this kind of chemotherapy application, we apply whole body hyperthermia, local hyperthermia, hyperbaric oxygen therapy in our clinic.
Which way around do you do it? You hyperbaric oxygen first, and then the hypothermia, or what? How do you do it?
Generally, we do hyperbaric oxygen first, followed by hyperthermia. It's not like a must that we do, but it's something we generally prefer to do. Yes. And the reason of these therapies being incorporated is firstly to potentiate our chemotherapy efficacy. Secondly, these therapies also have their own therapeutic effects, that's their own anti-cancer effects also. So not only increasing effectiveness of conventional chemotherapeutic agents, but also they also have their own anti-cancer therapeutic benefits.
Right. Now I'm going to say something to you, and you can judge it. I use fasting, always have done. I'm an amateur at this. You're much more professional than me. And I use fasting, but for example, if someone's going to have their IV, this is bog standard chemo in Britain. If someone's going to have their IV chemo on a Monday, I actually put them into a fast from Saturday night. So I make them almost do the Volta Longo program, because I talk about them having Sirtuin-1 being made at 6 o'clock on the Sunday night, 24 hours later. And so Sirtuin-1 shuts down their healthy cells and still leaves their cancer cells vulnerable. And I bring them up the fast at noon on the Tuesday. So we're doing it slightly differently, because you're just focused on the
it's very much about the clientele that you're practicing with. Our practice is mostly very advanced stage 4 patients, and in these kind of advanced stage patients, extended fasting can become a limiting quality of life affecting measure. Meanwhile, in earlier stage patients or stage 4 patients who have good general well-being, we sometimes do a similar approach of sometimes even 48 hours of fasting, sometimes more. Some of our patients do it. There is very good evidence, and that of course is a preferable measure if the patient's general well-being is suitable for it.
Okay, I just wanted to sort of do it and compare our little programs. Otherwise,
it's like
what me up saying, Chris, why did you make me fast for 3 days?
Like what you're doing practice-wise is correct. It's good. It's the ideal form. And Walter Longo's publications are also very valuable in this regard.
Yep.
Meanwhile, our limitation is, of course, the clientele that we're practicing with mostly, and so we want to always strike a balance between searching for effectiveness and protecting quality of life.
Yes.
And for us, the most crucial is for our patient to be fit to be able to receive their chemotherapy treatment.
Yep.
If they're earlier stage general well, or again stage 4, but good general well-being, cooperative patient, extended fasting will of course definitely be our preference.
Okay, right. So first of all, you give them hyperbaric oxygen, which is exactly what we do. We say go for it on the afternoon before. There is actually research from Arizona that you can ride a bicycle for 3 hours in the morning of your chemo, but I always say I don't expect my patients to do that because they're usually pretty tired. So you go for hyperbaric oxygen in the afternoon before. That's all right for you, or do you prefer to do it on the actual morning?
We prefer to do it on the actual morning before we start any chemotherapy session. Meanwhile, if possible, we'll do it the night before and then right before chemotherapy also. Like that will be even better. Yeah.
People don't realize, would you agree with this, that actually hyperbaric oxygen makes tumors crash? I mean, that's what I basically
definitely. Like tumors grow in hypoxic, low oxygen level environments. But besides this, one very important and that oxygen has a direct anti-cancer effect, which is very important. But besides this, a very high importance of it being applied prior to chemotherapy application is one of the underlying reasons of chemo resistance is hypoxia. So when you increase oxygenation in the tissue, you're actually getting in the way of chemo resistance or radio resistance, also. So that's why it's crucial to have it prior to chemotherapy application. Besides this, we see a great effect in hyperbaric oxygen, increasing quality of life of our patients and their chemotherapy tolerance also. Because before, we didn't start with doing all of these together. It was step by step. We openly saw after we added hyperbaric oxygen to our regime that patients tolerate the treatment better and their quality of life is much better.
Well, it's interesting because when I first wrote up hyperbaric oxygen probably about 17, 18 years ago, and I got attacked by the skeptics straight away, but they were suggesting that I was saying it would cure cancer. I didn't say that at all. I said it made chemo and radio work better and reduce the side effects. And a doctor attacked me in Britain and accused me of talking mumbo jumbo. And I found, that's your evidence point, I found a 90 study analysis from 2 professors in America who looked at hyperbaric oxygen, and it makes chemo work better, makes radio work better, reduces the side effects. And the reason is because cancer cells sort of borrow their systems from healthy cells around them. And those systems actually don't work if you crash the tumor. I mean, the tumor is hypoxic. It's got no oxygen into it. So why do you think, though? I mean, the same week as I got attacked, the Royal Marsden rang me up and said, we're going to do a trial. And it was an obscure cancer. I can't remember what it was. And they said, we're going to do a trial with hyperbaric oxygen and chemo. Why do you think it is that surely every oncologist who goes through medical school knows that a tumor is hypoxic, but none of them think to use oxygen?
Like I can't comprehend it also. I don't understand. Or like another question to you is a similar one is in almost all of our chronic diseases, we in conventional medicine, diet is said to be one of the most important cause of chronic diseases.
Yep.
May it be cancer, may it be other chronic diseases, but somehow dietary changes are not part of our treatment regimen. Like if it's the cause, it can definitely be used in its treatment also. But when I speak to our colleagues, they say like it's the last 6 months of the guy. Leave him, let him eat whatever he wants. Like well. Then why do any treatment? Like, but no, let's do the drugs, but no dietary modification. Like it's hard to understand.
It's crazy. And you know, people go in for their chemo into hospitals in Britain, and the opposite happens to them. They get given a bag of sugar immediately before their chemo. They give dexamethasone, which puts their blood sugar up, and they give a cup of tea and a chocolate cake.
You get the tumor stronger, ready for anything that's coming.
We like a challenge for our That's right. Right now, okay. So you use chemotherapy, and you actually use hyperthermia. Let's talk about hyperthermia before chemotherapy. Again, lots of research going right back to Coley's toxins in 19. So talk to me about hypothermia and how long you put people in the chamber for and what it's doing and so on.
Like we practice two forms of hyperthermia. One is whole body hyperthermia initially. In whole body hyperthermia, we heat the body for around 90 minutes. And then after 90 minutes of heating, we stop heating, but wrap the body up to conserve that heat for an hour or so more. In whole body hyperthermia, what we're doing is actually stimulating a fever in the body. And as we know, as somehow our body knows to increase the body temperature to cause a fever when we get sick. May it be a bacterial infection, viral infection, may it be, again, in cancer also. This increased temperature is important. Why? Because at increased temperatures, our immune cells function much more effectively. But to the contrary, other infectious agents, pathogens, cancer cells are much weaker because they cannot bear increased temperatures. Whole body hyperthermia treatment is a treatment which we're applying since 2010 or so. So it's one of the
you go to.
We don't have an exact target temperature. Every individual's immune response and increase in body temperature is different, but we do heating for 90 minutes. Generally, patients will go up to around 39 degrees Celsius or so. So it's quite a high temperature. It's one of the hardest therapies. Like in our eyes also, and based upon many of our patients, it's harder than chemotherapy or anything else. So it's a heavy treatment. The increased temperature, besides having a direct anti-cancer effect, it also has immune stimulating and immune modulating effects. So it assists in forming an effective immune response against tumors. Besides whole body hyperthermia, we also use local hyperthermia treatment, where the body area that has the most tumor burden is heated. And in local hyperthermia, the region that it's applied will be heated to around 46 degrees Celsius. This
how do you do that? Because it is coming on board in oncology in Britain, not whole body hypothermia.
Yes.
People, for example, have perfusion for their liver, don't they? And they get heated.
Yes.
You don't heat the chemo, you heat the person.
Yes, like there are different several different heat therapies entering conventional practices. May it be hyperthermic intraperitoneal chemotherapy, HIPEC, or may it be perfusional hyperthermia to the liver. Like what we are doing is using specific devices that heat the body region with it's called modulated electrohyperthermia treatment. So a kind of similar hypothesis, similar to a microwave oven, but for the body specifically. So we use modulated electrohyperthermia treatment, and with this treatment, the region that it's applied is heated to around 46 degrees Celsius. Right. This kind of heat has a direct anti-cancer effect. Besides this, by heating the region that has the highest tumor burden, you're actually increasing circulation to that area also, which increases chemotherapy drug delivery to that area. Besides this, there is a bunch of evidence regarding increased temperatures, heat, increasing chemotherapy efficacy. That's why HIPEC is coming into the treatment of peritoneal implants or ovarian cancer therapies, because it's currently in conventional practices, heat is accepted to stimulate and potentiate chemotherapy efficacy. So you're increasing circulation to the area, which increases chemotherapy drug delivery. Also, that heat potentiates the efficacy of the chemotherapeutic agents also. And also that kind of a temperature also has a direct anti-cancer effect also. So it's targeting cancer from multiple different ways, and together with this, of course, besides these therapies, lifestyle is very, very important. Like may it be exercise, may it be a personalized diet based on the condition, a ketogenic diet, or we can say a carbohydrate restricted diet is our main application in our clinic. And besides these, of course, all of these can be done, but in our eyes, none of them will translate into clinical efficacy if the patient doesn't have a positive mood and will and wish to get better. The only way of any treatment to work is them having positivity, belief in the treatment, and the will and wish to get better. If these aren't in place, anything you do, you might be doing the best treatment, all in place, but none of them will translate into effectiveness if that is not in place.
Well, this week of shows, this 8 days of shows, tries to cover every single one of these aspects. It really is.
This is very important. Like,
yeah, I agree. Okay, so now you've got the tumor in a muddle in terms of oxygen and hypothermia. You've also put up the immune system, and now you're going to hit it with chemo. So it is IPT, isn't it? It's insulin potentiation therapy.
Like IPT is the it's a practice, and it is similar to IPT. We mainly don't use the name IPT much. Why? It is similar to IPT because we also use insulin. But in IPT clinics, generally, the chemotherapy dosages are applied around 5 to 10% or so, much less compared to standard. And the main focus is on insulin application. In our eyes, like our focus is not insulin only. That's why we have named it metabolically supported chemotherapy, because the whole thing is, we think the focus should be initially accepting that cancer has a metabolic basis to it, and targeting cancer metabolism can translate into clinical efficacy. So the diet, the insulin is a metabolic modulator there. So when we say insulin potentiated therapy, it's like everything is insulin. The fasting is not important. The diet is not, like the metabolic basis. So we say metabolically supported chemotherapy. Do we use insulin? Yes. But compared to standard IPT clinics also, our insulin dosages are also much less compared to them.
All right. Let me ask you about that then. So you've given somebody insulin when they come in to further put their blood sugar down, and they've been on a 40
Yes.
fast.
Yeah.
But do you use it again immediately prior to the chemo or not?
We apply it right prior to chemotherapy, not when they come in, just prior to chemotherapy application.
Okay, so you don't give them any more insulin. You just you give them their chemotherapy an hour later or so. Yes.
Exactly. Yes.
And do you choose? This is the question I had for Matt, and he wasn't too sure. Do you choose the chemos that are appropriate for that cancer? Or
yes,
I mean, yes, you do. So someone with colorectal cancer would maybe get I don't know.
Like their FOLFOX, FOLFIRI, FOLFIRINOX. Like we generally will follow our standard conventional guideline-based algorithms.
Right.
Meanwhile, just because it came up, now sometimes a patient will come in. They have received all lines of chemotherapy, like in our guidelines, and then we'll apply a drug regimen that they received before and progressed under, but we'll apply it in a metabolically supported fashion. So metabolically supported chemotherapy with everything else, and they'll respond to that therapy.
Good.
Like we've had many patients like this. So the chemotherapy drugs, are they important? Definitely, they're very important, and we follow our conventional guidelines. Meanwhile, the part besides the chemotherapy is very important. Also, the way you apply the drugs is very important. In our eyes, the way we apply the drugs is very important. Okay. So metabolically supported application important, and incorporating it with everything else, this changes everything.
So now, as I understand it, I may have this wrong, you give 60% of the orthodox dose, or do you vary by patient?
Like it varies patient by patient. In our guidelines, there's a dose range, an indicated dose range. In a drug, let's say, we'll say apply this agent from 60 milligrams meter square to up to 100 milligrams meter square. A physician can choose 100 milligrams meter square. It's in the guideline, the upper dose scale. Generally, if you're doing a standard practice, that's what you will do. And in the guidelines, it gives you the choice to apply a lower dose also. We generally tend to apply the lower part of the dose scale, but again, in the guideline-based dose scale.
So if someone's coming to you, say it's a lady and she's coming for ovarian cancer, you would give her capecitabine and Taxol?
Possibly, yes.
Yes, possibly. Okay, and it would go, the dosage would vary. So basically, after she's had a hyperbaric oxygen and hypothermia, she then has her drugs. Now, explain to me, I think you mentioned something, then I didn't quite catch it. Do they just have one session of chemo when they're there that week?
Yes.
Or they do?
Yes.
And so when the chemo has finished, so they have their drugs for an afternoon or something like that, what else do you do with them after they've had their drugs?
Like the same day, they'll be getting everything. Like may it be the hyperthermia, the hyperbaric, high dose vitamin C, DMSO, these kind of supportive infusions. Also, the chemotherapy agents are even after we apply them, they're at a high concentration in the body for the initial 48 to 72 hours. So our cycles will generally be minimum 3 days of cycles, because we want to maximize the efficacy of that chemotherapy while it's in the body. So as an example, they'll get chemotherapy on the Monday, they'll get everything. But Tuesday and Wednesday, they'll also receive treatment with us, where they'll receive everything besides the chemotherapy, because that's the time when the drugs are at the highest concentration, and we have to focus on potentiating the efficacy as much as possible during that time.
So do you use intravenous vitamin C or just high dose?
Yes, we use intravenous vitamin C.
Intravenous vitamin C. And of course, intravenous vitamin C, I know from the Riordan Clinic, is supposed to work better if you've had hyperbaric oxygen and have been on.
Definitely.
Okay, good. So no. What about the purpose of intravenous, let's say turmeric? You use that or not?
Like it's not in our mainstream protocol, let's say. In some personal conditions, we do apply it, but it's not like the main part of our regimen. No.
Okay, fine. That's fine. I always wonder why people use it anyway. What about what about this highly controversial I'm about to say to you, because one of my patients who, frankly, I thought we cured, her oncologist suddenly announced that this is absolutely wonderful. Your tumors are all gone away. And now in the next 10 years, you've only got a 3% chance of getting the cancer back. She went into complete spin and she went to a clinic in Nevada. And the clinic gave her, immediately after her drugs, they gave her intravenous glutathione.
Yes.
I personally thought it was mad.
Like we don't do that.
Because it's going to negate the free radicals in the drugs, surely.
Yeah. Like these centers that do this are more like with a alternative approach, let's say. Like of course, let's think out of the box. We can do things out of the box, no problem at all. But our whole thing is, we say if we're doing chemotherapy, we're going to do it in the best way possible, and once we do it, we're going to potentiate its efficacy as much as possible. And yes, we can do things that can support our general well-being, but these should never be reducing the efficacy, even possibly. Like there shouldn't be any possibility of it reducing the efficacy of our chemotherapy. So we don't. We're very cautious about this.
Yeah.
And,
at the end of the day, you've got a very scientific, evidence-based approach. So have I. And as soon as she mentioned IV glutathione, I just went, "Oh no, please!"
Yeah.
It's got to be wrong. It's the opposite of what you would want to do. All right. So what else? When they're spending the next couple of days with you, they do IVC. What other sort of things would you do with them?
We will be doing like the hyperthermia, the hyperbaric is already there. The supportive infusional cares will be high dose vitamin C. We apply DMSO extensively. Based upon their individual condition, we also apply sometimes mistletoe. IV mistletoe is something we use. We'll always follow our patients' electrolyte levels, their vitamin levels. We'll supplement anything that's needed, maybe B vitamins, the calcium, magnesium, etc. And the supportive infusional care is personalized, more based upon the patient's condition. But high dose vitamin C and DMSO is like applied almost in all conditions.
Yeah. Now, okay. So then after the 3 days are up, they leave you.
Yes, correct.
What do you expect them to carry on doing? So if you've given them a dose of IVC and DMSO, do you expect them to go and find someone when they get back to England and carry on with IVC? or do you arm them with some more mistletoe so they can inject it in themselves, or take
Like,
pills, or what?
When we send patients back home, like as an example, a colon cancer patient, their schedule will generally be 3 days here, 10 days at home, like 3 days in Istanbul, 10 days in London, as an example. And when we send them back to the UK, generally, like we always give our patients specific drugs. Some of them are repurposed drugs. Some of them are drugs just in case they have any complaints, maybe nausea, etc. These kind of stuff. Also, we use some supplements with our patients also. So we'll give them the oral medications and supplements that they shall be using during that 10 days of time. All of that will be supplied by us. And any injection may be mistletoe, or sometimes our conventional bone marrow stimulating injections, these are also supplied by us to our patients.
What drugs do you use?
Can you repeat the?
I just wondered, what off-label drugs do you use?
Off-label drug-wise, we use doxycycline and metformin mostly.
Right. So you use doxycycline, you use metformin. Okay. I'm very apologetic about this. I use berberine, not metformin.
Like we use berberine also.
Yeah.
In our patients, not in all of our patients, but currently a very good form of berberine, liposomal berberine, came into the Turkish market. And we're before, the supplement availabilities in the UK market is much more extensive, supplement and quality choice-wise.
Yep.
But here we aren't able to always reach everything supplement-wise that we want. But liposomal berberine currently is available here, so we're starting to use it more. But metformin and doxycycline is drugs that we use.
Okay, I was going to ask you two questions then. Your attitude to cancer stem cells, which are the harmful cancers, is you'll use doxycycline to kill them.
Yes, but whole body hyperthermia also has effects. Hyperbaric oxygen also has effects against cancer stem cells.
Okay. Now, when someone goes home, I think I caught that they can come back. You have programs that they come back every 3 weeks. Did you say?
As an example, in a colon cancer patient, generally their treatment protocol will be 3 days here, 10 days at home. So 3 days in every 2 weeks of time. So Monday, Tuesday, Wednesday here, then 10 days at home, then Monday, Tuesday, Wednesday again here. This kind of a schedule.
How many sessions do you think they need?
Every patient's condition is different. Of course, this disease is a chronic disease, and chronic diseases need long-term treatment and follow-up. So our initial aim is trying to achieve regression of disease, possibly no evidence of active disease. But even then, this doesn't mean that the individual does not have cancer. It just means there's no detectable cancer scan-wise. And there is definitely microscopic cellular level of disease. So treatment should be continued at that time. Our schedules of treatment, if we're continuing chemotherapy, the dosage, these all change with time. If we're started with every 2 weeks, slowly we might change to every 3 weeks, then once a month. With time, we might stop chemotherapy totally and will be continuing with all of the other parts. The patients will come in frequently again, because this is a chronic disease. Some of them will do the main initial therapy with the aim to achieve regression, or if ever possible, no evidence of active disease, then we'll give them over to a practitioner in their home country to take it from there on. So every patient's condition is different, but we always tell our patients, they always have on mind, this is a chronic disease. We aren't treating an acute condition. Yes, of course, initial response is very, very important for us, but sustaining that response, sustaining the well-being is even more important for us.
Agree.
And that's in their hand mostly also.
I would say I'm trying to get the cancer under control. And once we've got it under control, then we can...
Exactly.
I've forgotten the question now. Your patients, I know what it was. Your patients, are the majority of them stage 3, stage 4?
Majority stage 4.
Majority stage 4. Okay. Yes. And do people stay in your building, or do they go to a hotel over the road? I mean, these practical issues are quite important.
Yeah, of course. We work at an outpatient basis, like they'll stay at nearby hotels. Meanwhile, if patients need inpatient care, we have inpatient capabilities also, and we again deliver care as an inpatient also. But majority of our patients will receive treatment at an outpatient basis, as long as there isn't a underlying medical necessity for them to be an inpatient.
Okay, I can understand how the protocol works with breast cancer, prostate, breast cancer, colorectal cancer, ovarian, and everything else. My dilemma with patients is prostate cancer, because prostate cancer in my book is a very different cancer, and us men, we don't have chemo for our prostate. It's only if it goes to our bones or our lymph that they get the dose out. Do you have anything in your bag of tricks that actually would take out the tumor in the prostate, or are you also doing really treatment only when it's gone to the bones and the lymph?
No, like one possible therapy in local prostate cancer is prostatic hyperthermia treatment, where you're heating the prostate directly to 45 degrees or so, which has very effective results. Like we currently do not have prostatic hyperthermia, the device exactly here. It's in Germany. A colleague of mine does it. But what we do in such patients is radiotherapy treatment to the prostate gland directly. And together with that, local hyperthermia treatment and everything else also is applied. Prostatectomy is something that is given as an option to patients, but such surgical interventions, long-term results, quality of life, sexual function, these are very much affected. But radiotherapy, local hyperthermia, and these kind of interventions, the quality of life is also much better. Sometimes a watchful wait also is an option in these patients, like not doing any conventional intervention, just doing basic interventions and following the patient, because it's not always an aggressive condition. So watchful wait also is an option. We generally like the patients we get are generally patients who have received several lines of therapy, who will have multiple bone metastases, and then they'll come to us. In that condition, of course, we'll be doing infusional metabolically supported chemotherapy with everything else that we priorly mentioned. And we have very, very good results.
When I started this a long time ago, this is amazing, about 2 years after I started this, so 2004, 2005, we have a magazine that goes into 640 hospitals in Britain. It's about to be launched again in February. And 7 urologists wrote to me and said, would you please look at HIFU because it really should be used more widely, HIFU being high intensity focused ultrasound and a form of ablation. And hypothermia is a form of hypothermia. And they basically said because drugs companies want to kill it. And this right? I mean, I'm not too sure they should have sent it to me, but never mind. I did look at it, and I favor it, and I favor if it's confined. I favor doing some sort of ablation. I favor nanoknife like that, really. So, are you saying your hypothermia treatment can do much the same job?
Possibly, yes. Like my brother-in-law is a urology specialist. And we were chatting like once, like, because prostate cancer is very frequent, you know, like said like we might get it one day. I said
when I got to 70, I got a 76% chance of getting it.
So I said, like, will you have prostatectomy? Because, you know, it affects your quality of life and sexual function very much. And he said that no, I won't. So that's urology recommendation. He said he wanted.
All right, I thought I'd ask you because it's such a different cancer, and
it's very different, and it needs a total different approach. The way it acts, the way it will progress, the way it should be treated is totally different. Yes.
I think I've grilled you enough, actually. I don't know whether you feel that you've been grilled.
Like I can very shortly, just as an addition, because I think it can be beneficial for the audiences. Like our main difference with me and my colleagues is also we value publications. Like we think that the only way of showing something is effective is scientifically publishing in peer-reviewed journals. So we've until now we've made several publications. Our first publication goes back to 2015 regarding a locally advanced rectal cancer patient that we treated at that time. And the initial first-line treatment for locally advanced rectal cancer is surgery, and surgery seemed to be the only curative approach. Meanwhile, that patient at that time, she came to us. She was 81 years old, and she said like her only will is to not have surgery. So she was open to anything else, but at another hospital, they had found her ineligible to receive any chemotherapy because of her age. And we took her on for therapy and treated her with metabolically supported chemotherapy, hyperthermia, the diet, and she had complete and radiotherapy treatment. And she had complete response to treatment, and we published it 3 years after as a follow-up. So no recurrence, nothing. At that time, we in our conclusion, the point we came to was initially, firstly, a patient at an advanced stage can, at an advanced age of 81, can tolerate chemotherapy when it's applied in a metabolically supported fashion. This is important because normally such patients are not able to tolerate high-dose standard regimens. In this approach, treatment can be applied, it's tolerable, and also it's effective. Secondly, we said this kind of a combinatorial approach of metabolically supported chemotherapy, hypothermia, and radiotherapy can be an alternative curative approach instead of surgery. We made our second publication in January 2016, where we published our treatment outcomes in stage 3 and 4 pancreatic cancer. And in this patient group, generally in a standard approach, in a stage 4 patient, the survival time can be as short as 3 months or so, the 3 to 6 months. And in a stage 3-4 pancreatic cancer, in our guidelines, it will be said the survival time is 6 to 11 months. And the 1-year survival rate is 20 to 45% or so. It's said, but it seemed to be even much less generally. In our patient group, which we treated until December 2014, in a 33 patient group, our median survival time was 19.5 months, and 54% of those patients were still healthy, alive when we made our publication. And our 1-year survival rate was 82.5%. So much more than a standard regimen, which shows how much more effective treatment can be when we incorporate an integrated approach. Again,
I don't doubt your figures in the slightest, because things like FOLFIRINOX, someone's got enough problems on their hands with pancreatic cancer. They get 5 drugs in very, very high doses, no protection at all. And what you're doing, you're actually lowering the dose, but you're giving them protection. It work better. It's
again, another very, very important publication of ours is we made it in 2020 in stage 4 non-small cell lung cancer. And our study was carboplatin paclitaxel chemotherapy regimen being applied in a metabolically supported fashion, together with hyperthermia, hyperbaric oxygen, and everything that the ketogenic diet. And in this patient group, in the carboplatin paclitaxel chemotherapy regimen, in our guidelines, again, the survival time, the overall survival is 6 to 11 months. And in our patient group of 44 patients, our overall survival was 42.9 months, and our patient groups, all of them were stage 4 patients. When we compare our patient group with the other carboplatin paclitaxel drug trials, which are reported in our guidelines, our patient group is much more advanced. The brain metastasis frequency was again more. The performance status of our patients were worse, but they were able to tolerate treatment. Their response was much better, and they lived much longer. So what we say is this isn't an alternative approach. What we're saying is chemotherapy can be potentiated. It works much better, and these complementary approaches definitely have very high effectiveness. Again, lastly, a very important example for a patient we published in 2021, end-stage breast cancer patient. She came to us back in November 2018 with oxygen support from United States. She was sent home with very short life expectancy, found her ineligible for any sort of therapy. And I remember the day she came in to the clinic, I couldn't believe how she came even with oxygen support, and brain metastasis, lung metastasis, liver metastasis, intra-abdominal lesions, bone metastasis, end stage patient, and from Ohio, United States. And we took her on for therapy, and following 3 months of treatment, she had nearly a complete response to treatment. We continued her therapy 3 months more, and her post 6 months treatment PET scan reported complete response, no evidence of active disease. She had brain metastasis. At the time that she came, her general well-being wasn't suitable for any sort of radiotherapy, and because the standard approach is doing radiotherapy directly. But her general well-being wasn't fit, and we said let's follow this condition. And with this treatment, we saw complete resolution of the brain lesions also. So no evidence of disease there. Right now it's end of 2022, so 4 years since she came to us, and 3.5 years since we sent her home, healthy, alive, living her normal life. And so this is possible. It's just about the treatment that you're applying. And one important thing is, at such an advanced condition, she believed, she said, you do the treatment you believe is the best. I believe in it, and I think I will live. And she had a positive mood, relaxed, very high will and wish to live, and she lived.
Yeah, determination, biology of belief it is. I believe very, very firmly.
Definitely.
I believe
definitely.
no one's terminal, and I want my patients to believe no one's terminal.
Exactly. Likewise.
Yeah. It's I'm going to ask you, this is a question from left field, just to show everybody we haven't rehearsed this. I'm doing a lot of work at the moment on Epstein-Barr, HPV, herpes, but most importantly, cytomegalovirus, because cytomegalovirus has been found in every brain tumor, whether it's primary or secondary, and it's seen quite active in metastasis in breast cancer and so on. I'm going to offer a view, and you can shout at me. It seems to me that your approach, if you're going to use oxygen, hyperbaric oxygen and hypothermia, you would actually boost the immune system quite a lot using those two treatments anyway.
Definitely.
I would think with your treatment, you don't have to worry about viruses, whereas I do worry about viruses. I think they can be the driver of extreme progression.
Definitely. Definitely. Definitely.
Okay, right, we agree again. Well, look, we'll stop it there.
Well,
I think from my amateur professional way,
it's science, Chris. It's science. It's evidence based. Like that. Of course, we agree. We have to agree what science tells us. Like, unfortunately, everybody's not open to see the science, but
especially in this day and age. Especially this day and age. Our whole week is called "Cancer: Why You're Not Doomed." And this is the final show of the week. And I think you're agreeing with me that I don't believe cancer is doomed at all.
Definitely.
I think one thing I would just chuck in, you talk about your metabolic approach, but one thing I've been looking at as well is how you're not doomed in the sense that you don't actually have mutations in your DNA. You can inherit BRCA1 and BRCA2. But what happens is doctors, when they talk about KRAS and BRAF and things like this and call them mutations, they're not actually mutations. What's actually happening is the DNA has no new mutations in it, and it's been copied into mRNA, which is copied into proteins, and it's the copying process that's gone wrong in the microenvironment of cells. And Christine Mayer of Sloan Kettering, literally in October last year, proved that. She's won the National Institute of Health Young Turk of the Year award or something. But we've had several studies that say that's right in the past. And I think that cancer is every bit as metabolic a disease as dementia, as is cardiovascular and things like that. And the sooner, the system wakes up to that, I think the better everybody's going to be.
I think so too.
Thank you very much for your time.
Thank you very much.
Me, Cancer Active, all the patients and viewers watching this, I really, really want to thank you for ending our series.
Thank you very much. Lovely to talk to you. Thank you.
Excellent. And you. Bye.